Endocrinology and reproduction summary. Do know that diencephalon contains thalamus, epithalamus, and hypothalamus. Do know something about hypothalamus and do know something about epithalamus as well. Before I talk about hypothalamus and epithalamus, let me remind you that hormones are chemical messengers that are secreted by any endocrine glands and they are dumped directly into the bloodstream. Hormone concentration is commonly controlled by negative feedback, and I went over it in the lecture. Negative feedback. Feedback that says, tone it down. So hypothalamus produces hormones that talk to the anterior pituitary and either stimulate the synthesis or inhibit the synthesis and secretion of one or more hormones from the anterior lobe of the pituitary. When hormones stimulate the synthesis and secretion of one of those hormones, we call these hypothalamic hormones releasing hormones. Do know that hypothalamus can also talk to the nervous system. It namely activates the sympathetic motor pathway because it projects to the intermediolateral horn segments. Now let's talk about epithalamus. Epithalamus is primarily made up of pineal gland, and the hormone that is produced by the pineal gland is called melatonin. Melatonin is very important for circadian rhythms. Circadian, circa is around, dia is day. Melatonin. Overproduction of melatonin in certain but not all individuals, what we call those individuals sensitive individuals, may result in a disorder called seasonal affective disorder. It has now been changed to major depressive disorder, abbreviated MDD, with seasonal pattern. All right, so that was hypothalamus, epithalamus. Let's talk about the pituitary. Pituitary, some people like to call it master endocrine gland, but what I want you to know is that it's got 3 lobes. That's all that matters. Okay? 3 lobes and what hormones are produced from those lobes. The larger one is obviously the adenohypophysis, the glandular hypophysis, and it produces the flat pig hormones. Went over them in class: FSH, LH, ACTH, TSH, prolactin, and growth hormone. And for example, growth hormone, what it does with a name like growth hormone, it goes and talks to the cells, to any tissues in the body, and stimulates cell metabolism. So cells increase in size and start dividing and increase in size furthermore. So how does it do so? Well, obviously, final purpose is to make more protein. But growth hormone also produces energy for the body by breaking down, increasing breaking down of fats and carbohydrates. Do know that the disease where growth hormone is increased post-puberty is called acromegaly. Acromegaly. And I'll show you pictures in class. Another hormone I want you to know is called prolactin, abbreviated PRL. It's also sometimes known as lactogenic hormone, and with a name like that, lactose is a Latin for milk, so just like lactose, anything to do with lact is milk, so it increases production of milk. MSH is produced from the middle, is produced in the middle lobe of the pituitary, and MSH stands for melanocyte stimulating hormone. So this hormone stimulates melanocytes. It stimulates melanocytes. What do melanocytes do? They increase pigmentation. They make melanin, and therefore excuse me, and therefore pigmentation or darkening of skin takes place. Melanocyte stimulating hormone, also M for the middle lobe. Now let's talk about posterior lobe. So posterior lobe does not make any hormones. It only stores hormones. And those hormones are two, oxytocin and ADH, another name, vasopressin. ADH is also known as vasopressin, but you want to know the full form. It's called antidiuretic hormone. You do know that diuretic means pee, antidiuretic means no pee. So do know this hormone as a no pee hormone. But what is really interesting is that both of these hormones are actually made in the hypothalamus and just delivered to the posterior pituitary, which is also known as neurohypophysis. And it's called neurohypophysis because it's got a direct connection to the hypothalamus, to the neuronal area, so as to say, neurohypophysis. The anterior pituitary is called adenohypophysis. This is like a glandular pituitary. Okay, so how do you get hormones from the hypothalamus to the posterior pituitary, the neurohypophysis? Well, there is a stalk that you can actually see with the naked eye, and that stalk is called infundibulum, and that stalk connects hypothalamus to the pituitary. So do know that oxytocin, tokos, is a Greek for contractions, uterine contraction, the labor, and oxytocin, what it does, it contracts the uterus, but it also contracts the glands, the milk glands, the mammary glands, so that milk ejection happens, milk let down happens. All right. Now let's talk about ADH, antidiuretic hormone. What it does, it grabs pure water, not water associated with sodium or any other sugar or a protein like albumin, pure water. It grabs pure water and takes it back from the parts of the kidney, the tubules of the kidney, namely the collecting tubules of the kidney where urine is collected, and sucks it back into the vasculature, into the blood. So it therefore maintains body's water content. And remember, it does so by sucking in pure water. So if this cannot happen, if the posterior pituitary can no longer release adequate amounts of antidiuretic hormone, obviously that would be like I showed you in the class, very low no-pee levels, right? And patient would be peeing a lot, insipidus, and this is called diabetes insipidus. Insipidus stands for tasteless. Do not confuse this with diabetes mellitus. Mellitus is meal, honey, melly, honey, sweet. Diabetes insipidus is caused by either very low production of ADH or lack of the receptor function. Okay, do know the terms. Polyuria means excessive urine production, and it can happen both in diabetes mellitus and insipidus. They will ask you one way or another about diabetes mellitus, and do know that all forms of diabetes, mellitus and insipidus, are prone, patients with both forms of diabetes have increased urination, polyuria, and because they pee a lot, they also have increased thirst, and that's called polydipsia. All right, let's go over the adrenal gland, the pancreas, thyroids, parathyroids, and the thymus. So adrenal gland sits just above the kidney. I showed it to you in class, and it can be very easily recognized by its pyramidal shape. because it sits just above the kidney, it's sometimes called suprarenal gland. So the inner part of the adrenal gland is called medulla, like the inner part of bone, like the inner part of many organs. The outer part is called cortex. There are 3 layers of adrenal cortex. Let's call them layer 1, layer 2, and layer 3 for now. 1, 2, 3. But as you know already from the lecture, these layers also have their own names. And from outside to inside, 1 is called zona glomerulosa, 2 is called zona fasciculata, and 3 is called zona reticularis. And these layers are responsible for salt, sugar, and sex control. Okay? So just remember that all of the cells of the adrenal cortex produce corticosteroids. Okay? They all derive from cholesterol. Corticosteroids all derive from cholesterol. Aldosterone is the first one that you need to know. We'll also talk about cortisol and we'll talk about testosterone. Aldosterone is we call it mineralocorticoid because it is responsible for absorption of sodium, which is a mineral. So it takes sodium from urine and tries to keep it in the body. So we call it sodium reabsorption. When sodium is reabsorbed, potassium is always excreted, kicked out by the kidneys. This is something that you'll be studying in more detail in your core classes in pharmacology, but just know that sodium always brings water with it. And so tumor of this area is called Conn's syndrome. What is really important is because a lot of water is reabsorbed with sodium. Blood pressure rises, patients present with hypertension. Fluid and salt travel together, hypertension. Please remember, aldosterone secreted from zona glomerulosa, layer 1 here, zona glomerulosa. Cortisol is secreted from layer 2. All right, so first of all, cortisol secretion is controlled by ACTH, adrenocorticotropic hormone. So this is the hormone produced in the hypothalamus, in the pituitary. The hypothalamic hormone would be corticotropin releasing hormone. So this is a good example maybe. So hypothalamus releases this hormone, talks to the pituitary. Hypothalamus releases CRH, talks to the pituitary. Pituitary releases ACTH. Now you need to know that ACTH talks to the second layer of the adrenal cortex, and that's called zona fasciculata, the second layer. And that second layer, zona fasciculata, is responsible for making of cortisol. We call them glucocorticoids, and one of them is cortisol. Okay, adrenocorticotropic hormone, ACTH, drives production of cortisol. If we have a tumor sitting here in the second layer, zona fasciculata, that tumor is not called Conn's syndrome. Conn's syndrome is the tumor of zona glomerulosa. Conn's syndrome, zona glomerulosa. Okay? We are talking about zona fasciculata, the second layer. The tumor here is called Cushing's. So tumor here produces too much of cortisol, and the patient's presentation results in a Cushing's syndrome or Cushing's disease. So just to clarify, I want you to know that ACTH is made in the brain. If there is too much of ACTH, there will be too much of production of too much of cortisol. So if there is a tumor making ACTH, then we call it Cushing's disease. If there is a tumor making cortisol, because the tumor is located here, we call it Cushing's syndrome. Cushing's syndrome can also be due to medications. So the third layer, zona reticularis, produces sex hormones. Testosterone is one of them. Okay, and do remember that aldosterone, cortisol, and testosterone are responsible for salt, aldosterone, sugar, cortisol, and testosterone, obviously for sex. And obviously cortisol is a stress hormone. Sugar is like a side effect. Sugar elevation, glucose elevation in blood is a side effect of that. Just a way to remember. Okay, so what about medulla? What about that middle part sitting right here? Medulla. Let me do it in purple. Okay, so that part is called medulla inside, and what it secretes is epinephrine. Epinephrine. So medulla secretes epinephrine, going backwards. Medulla secretes epinephrine. Zona reticularis, that's the third layer from outside, secretes testosterone. Zona fasciculata, that's the second layer from inside, secretes cortisol. And the outermost layer, that's the third layer from inside, which numbers don't matter. We don't number them. We say GFR. GFR, from outside to inside, zona glomerulosa fasciculata reticularis. G stands for aldosterone. Okay, A goes first, aldosterone. So please remember that. Epinephrine is released by the adrenal medulla. All right, now let's talk about, so all of these hormones that I went over are steroid hormones. Steroid hormones, okay? Testosterone, cortisol, aldosterone, those are all steroid hormones. Now let's, what is an alternative? The other hormone types would be protein hormones, okay? Protein hormone would be what? For example, insulin. For example, it's counter hormone, it's antagonist, the hormone that does the opposite of what insulin does. Insulin drives sugar into the cells. Glucagon, also a protein. Oxytocin and epinephrine. Look at this. Insulin, glucagon, oxytocin, epinephrine. These are all protein hormones. Epinephrine, purely from a technical point, is an amino acid. Amino acids are building blocks of proteins. Okay, so group it as a protein. Now, let's go to and talk about diabetes mellitus very briefly. I'm not talking about diabetes insipidus. That's a problem with ADH, antidiuretic hormone. I'm talking about diabetes mellitus. The problem here is a problem with insulin, either decreased production or increased resistance. And many of you were saying increased resistance. That means that we make insulin, but the cells do not respond to insulin resistance. Okay? Where is insulin made? It's made in the beta cells of the pancreas, namely in the islets. So pancreas looks like so, got a tail, and if you use a microscope, you're going to see little islets here, little islands with cells. Those cells are either alpha or beta. It's beta cells that make insulin and alpha cells that make glucagon. Glucagon, once again, is an antagonist of insulin. It does the opposite action. So insulin lowers blood sugar, blood glucose. What about glucagon? It increases blood glucose. All right. So if a patient is unable to lower blood sugar, what happens is that all of that sugar stays inside blood. Patients pee a lot of sugar. That sugar draws water with it. The sugar, salt, and albumin. They hold on to water very strongly, and patients pee out a lot of water. That's called polyuria. All right, and don't forget that polyuria is found both in diabetes mellitus and diabetes insipidus. So what about glucagon? So what glucagon does is that it is released, and then a liver sees glucagon as an order to take glycogen. As I told you, gen means generator. So glycogen is a hormone, is a storage form of glucose. So glycogen is broken down into glucose pieces. Glycogen is broken down and released into blood. Once again, it's the alpha cells of the pancreas that make glucagon. Epinephrine, let me repeat again, is a hormone we went over earlier, and it's made in the medulla. Do not confuse. Epinephrine is a protein hormone. It is not a part of the aldosterone, cortisol, or testosterone trio. These three are responsible for salt, sugar, and sex control, and are made in the zona glomerulosa, zona fasciculata, zona reticularis of the cortex, adrenal cortex. Epinephrine is made in the medulla. All right, let's talk about the thyroid gland. Thyroid gland mainly produces T4, which is known as thyroxine. So thyroxine is converted in our peripheral tissues from T4, and we make from this T4 in the peripheral tissues, we make a hormone that is called T3, and its full form would be 3 stands for tri. So tri, it's got 3 molecules of iodine. So triiodo, standing for iodine, and thyronine. Okay, so triiodothyronine is another name for T3. I know I prefer T3 too. Triiodothyronine is a hormone that is secreted in very small amounts by the thyroid and is mainly produced from T4 in the periphery. Okay, so do know that if T3 or T4 are decreased, patients present with hypothyroidism, and this comes with mental retardation. So parathyroid hormone is produced by the parathyroid glands, which are 4 endocrine glands at the back of the thyroid, and their claim to fame is to regulate calcium levels. Calcium levels both in blood and tissues. So parathyroid hormone is abbreviated as PTH, and what it does is that it increases levels of calcium. Increased levels of calcium are called hypercalcemia, but what it does to phosphate is that it decreases it. So calcium and phosphate go hand in hand. Our bones require calcium and phosphate. Let me just, well, the formula is this. Some of you have had chemistry. So calcium, phosphate, right? So calcium and phosphate are both necessary to make bone. You studied this in your anatomy part 1. I know that because I teach both. Calcium phosphate is called hydroxyapatite. So let me remind to you that PTH, what it does is that with a name like PTH, how do you remember it? It is phosphate trashing hormone. So it gets rid of phosphate, you urinate it out, but you hold on to calcium. So it causes too much of calcium, and the resultant problem is hypercalcemia, and this may lead to, because you're losing the phosphate part, what may happen if someone has too much parathyroid hormone, parathyroid hormone, too much of it, that's hyperparathyroidism, bones may become a little bit softer because calcium phosphate hydroxyapatite is what makes bones harder. So when bones become soft, patients have deformed bones similar to rickets in kids. So last endocrine gland that you need to know is thymus, and thymus produces a hormone called thymosin. With a name like that, it's obviously it was found in thymus, thymosin, and thymosin is thymus is a very important gland because T cell development and differentiation happens in the thymus, not birth. All T cells, all blood cells are born in the bone marrow. However, T cells undergo education in the thymus. So as I mentioned, thymus shrinks by age 3 and is replaced by fat and connective tissue. So let's talk about syphilis very briefly. It's a sexually transmitted disease caused by bacterium called Treponema pallidum, or just abbreviated as T. pallidum. This P over here should remind you that the best treatment for Treponema pallidum is penicillin, the antibiotic called penicillin. Syphilis presents on a patient. That means you can first see signs of syphilis. It's a very rare disease, by the way, okay? Extremely rare. Used to be very common 100 years ago. So if anyone does have this rare disease called syphilis, what you're going to see first is an ulcer on the external genitalia. In case of a female, external genitalia has a collective term, which is called vulva. All right. Now, when we compare gonads of a male versus gonads of a female, they both have their own names. Ovary is the female gonad, testis is a male gonad, and because they arise from the same progenitor tissue, from the same tissue, we call them homologs. Okay, so this tissue in a baby, not inside the uterus, may become a male tissue or a female tissue. These two are then homologs. Okay. For example, a male has prostates, females have Skene's glands. Both of these derive from the urogenital sinus in a yet undifferentiated little baby. Okay, so let's talk about the uterus. Do know that Greeks call uterus metron. Greeks call muscle myo. You know this from studying the heart. Myocardium is the muscle of the heart. Myocardium had endocardium covering the inside of it and pericardium covering the outside of it. Similarly, myometrium is the muscular layer of the uterus that has an endometrium on the inside and the perimetrium on the outside. Perimetrium is a very tough membranous layer. Obviously very tough. Why? Think about the weight of the baby that the uterus has to carry around. So perimetrium is the membranous outer layer of the uterus. Peri meaning around. So because the inside layer is a muscle, Muscle can be stimulated, and we already went over it. It can be stimulated by oxytocin. Oxytocin stimulates both the muscle of the uterus, causing oxytocin, tokos meaning labor is in the name, but it can also stimulate the muscles of the breast to squeeze out the milk, so mammary gland, to secrete milk. All right, so stimulation of the uterine muscle, meaning myometrium, causes contraction during childbirth. We call it labor. Do you know the term parturition? Parturition is a fancy word of saying childbirth, often asked in the core classes. So there is so we did talk about placenta when we're doing week 3, and I told you IgG, immunoglobulin G, can go through the placenta and enter the fetus's circulatory system, blood, right? So placenta is that temporary organ that forms within the uterus, and its function is to exchange food and oxygen, nutrients and oxygen, and take them from the mommy and give them to the baby. Now, baby obviously produces waste products. Baby is alive, and those waste products have to go back to mommy because baby, there is no way a baby can excrete those into the environment. So the only baby's environment is essentially the uterus, right? So baby gives all those waste products to mom, and those waste products are something that mom excretes, and waste products actually are, among others, carbon dioxide, okay, and many more. So, so the uterus is shaped somewhat like a pear, and let me draw it, and so like so. So if this is vagina, so vulva is on the outside, vulva, this is vagina, there are parts of uterus that kind of protrude into vagina, okay? This is called cervix, parts of the uterus that protrude into the vagina, okay? And this part is really important because this is where, especially around this area, what we can do is look for detection of cervical cancer. We use we use a test called Pap smear. Pap smear, actually we talked about Greek last names today. Papa Nikolaou is the real name, Pap smear. And what it does is it helps early detection of cervical cancer. And this is the sole reason why cervical cancer went from being #1 among gynecologic cancers in ladies to #3, a distant #3 in the United States. So, so the male gonads are called testes. They make the male germ cell called sperm. The female gonads are ovaries, and they make the female germ cells called ovocytes or an eggs or an oocytes. And the process of formation of these female germ cells is actually called oogenesis. Do you know the difference between an egg and a follicle? A follicle, each ovarian follicle, contains an immature egg and its surrounding tissue, which is very important for creating the right environment for that immature egg, so that that immature egg can actually mature, and eventually that mature egg leaves the ovary, and the ejection of this mature egg from the ovary is called ovulation. The very last step leading to ovulation is an increased production of the luteinizing hormone by the anterior pituitary. And because this increase is very sudden, and we can actually measure sudden increases of the luteinizing hormone concentrations in blood, we call it the LH surge, which is the final push to the ovulation. And do note that in female, there is only one viable ovum per month. So when this mature ovum leaves the ovaries, it needs to be transported from the ovaries to the uterus. And the uterine tube, also known as the fallopian tube or the oviduct, is responsible for that. It does so by smooth muscle contractions, i.e. peristalsis. You've heard this term in your gastrointestinal classes. But also the cells that line the tube on the inside have hair-like projections called cilia, and this ciliary beating in unison helps move this egg toward the uterus. The egg, or a fertilized egg, which is called zygote, to the uterine cavity. So if a pregnancy happens outside of the uterine cavity, then we call it ectopic pregnancy. And you have to remember the word ectopic is very easy to break down into topos and ek. Topos means place and ek means outside. So outside of the normal place pregnancy, ectopic pregnancy. All right. So if the zygote is made, if the zygote is made because an ovocyte did meet the sperm, but this pregnancy, this fertilization happened in the wrong place, and the zygote cannot reach the uterus, we call it an ectopic pregnancy, and that's defined as an embryo implantation in any other site than the uterus, because normally the embryo should implant in the endometrium. So there are 3 steps that lead to a passage from ovaries to passage of the eggs from ovaries to the uterus. Step number 1, egg jumps the ship, is caught by the fimbriae, and these are finger-like projections of the fallopian tubes, okay, that surround the opening into which the egg has to enter. The part of the tube that is the closest to the ovary is shaped like a funnel, and in Greek that would be infundibulum. There is a F-U-N in that word, and that should help you to remember the word infundibulum. So fertilization is a zygote formation. That's when an egg meets the sperm and they unite and form the one-celled baby. So this zygote formation happens in the second part of the uterine tube that is called ampulla. Okay, and so it's this zygote that moves down the uterine tube, and as it does so, just before it reaches the uterus, it actually starts dividing very quickly and forms a ball-like mass of cells, but that ball-like mass of cells has some cyst-like cavities in it, and so we call that mass blastocyst by day 6. And you do need to know that it's this blastocyst that implants in the endometrium, and implantation is when this blastocyst attaches itself to the endometrium of the uterus, and remember, it sticks on day 6. The blastocyst implants on day 6. All right, so as I mentioned, a mature follicle contains an egg and its surrounding tissue. Mature follicle is also known as Graafian follicle, and after this egg is released from this mature follicle, whatever tissue is left over in the ovary is called corpus luteum. Luteum means yellow, and the color of this little collection of cells is yellow because they make a hormone called progesterone, and progesterone is a derivative of cholesterol, and you've all seen cholesterol in the egg yolk. It's yellow in color. So corpus luteum makes progesterone. Progesterone obviously helps maintain pregnancy, and I'm saying obviously because it's in the name, progestational. Progestational helps maintain pregnancy. Corpus luteum actually requires help to produce progesterone. That help comes from the luteinizing hormone initially. So luteinizing hormone helps form and maintain this corpus luteum right after ovulation. But later on, the embryo, actually the placenta of the embryo, makes human chorionic gonadotropin, HCG, which is very, very similar to LH. And it's this HCG that stimulates production of progesterone by corpus luteum after the implantation on day 6. It sticks on day 6. So if this fertilization does not occur, then corpus luteum becomes a scar tissue, basically stops working, and because of different coloration, now this corpus luteum is no longer yellow, it's more whitish in color. We call it corpus albicans. Albus is white. So just remember that LH surge, sudden increase of LH causes ovulation. You all know that in males, testosterone is necessary, and you all know that LH, abbreviated for luteinizing hormone / love hormone, is responsible for making of that testosterone. Testosterone is very important for making sperm. And this testosterone in a female is actually converted into estrogen. And we can actually see a sudden decrease of estrogen in blood right after this ovulation because the LH goes down, and so testosterone production goes down with it for a brief moment, and that can be measured in decrease in estrogen concentrations in blood. All right, now let me recap it all. The ovarian cycle starts when the anterior pituitary secretes the FSH, the follicle stimulating hormone. This follicle stimulating hormone picks one immature follicle in the ovary and helps it grow and develop into a mature Graafian follicle. In the end, Graafian follicle ruptures and the egg is released into the uterine tube. Somewhere halfway through the uterine tube, the egg gets fertilized, and when the egg gets fertilized, the product of the egg and the sperm is called a zygote, a one-celled little baby. This zygote starts rapidly dividing and moving toward the uterine cavity. By the time by around day 6, we call that mass, the little clump of tissue, a blastocyst because it's got a few cyst-like cavities in that little ball of cells. So this blastocyst then implants in the uterine endometrium. Implantation means adheres to it, kind of grows into it. So the blastocyst implants, it sticks on day 6. Now, obviously, the question that comes to mind is how come the endometrium is ready to take up that mass of cells? And the answer lies in the phase 1 of the ovarian cycle. So the phase 1 is obviously called the follicular phase because we just spoke about the follicle growing and then finally ovulation, where the follicle jumps the ship leaves the ovary and enters the uterine tube. Well, fine. What happens to the follicle is pretty clear, but during the time the follicle is growing, the endometrial lining is not sitting still. It's undergoing a rapid cell division and proliferation of its own. So the endometrium undergoes proliferation. This only happens during a part of the follicular phase, and that part is called proliferative phase. And during that proliferative phase, endometrium grows in thickness and gets ready to make that carpet-like cushion where it can welcome the blastocyst to implant. Now, obviously, that carpet-like cushion requires some kind of a maintenance, and that maintenance happens because body produces increased levels of progesterone, which can maintain that thick endometrium that is preparing to receive the fertilized ovum. This increased progesterone, as I mentioned earlier, is made by corpus luteum, the part of the follicle that remains behind in the ovary. And because it's the corpus luteum that makes this increased progesterone, we call this part of the ovarian cycle the phase 2. We call it the luteal phase. And the part of the luteal phase is the secretory phase. During that part, the endometrium is already as thick as it has to be, and this thick endometrium secretes everything it needs to ensure that that implantation of the blastocyst to the endometrium, implantation of the blastocyst in the endometrium happens happens successfully. So let me summarize it again. There are two phases of the ovarian cycle. The first phase is called follicular phase. A part of that phase is called proliferative phase because the endometrium is also growing as well as the follicle. And the second phase is called the luteal phase because the corpus luteum is making all that increased progesterone. And during that phase, progesterone makes sure to maintain the thickened cushion-like endometrium, and that cushion-like endometrium secretes its own chemicals and hormones necessary to ensure a successful implantation. So you do need to know that the average cycle, average length of the uterine cycle is about 28 days. It varies depending on many factors. And this uterine cycle is otherwise known as the menstrual cycle. And obviously, after 28 days, if the menstruation does not take place, the levels of progesterone go down because corpus luteum is no longer maintained by the placental HCG that I talked about earlier, the human chorionic gonadotropin. So there is insufficient stimulation of corpus luteum. Corpus luteum does not make enough progesterone. Decreased progesterone results in death of the uterine endometrium, and that dead uterine endometrium is shed and we can see that shedding as menstruation. This menstruation happens once about 28 days as a part of the menstrual cycle, and we then say that the cyclical shedding of the lining of the uterus in response to hormonal levels, obviously in response to a drop in progesterone, is called menstruation. You do need to know the term menarche. Menarche is the first menstrual bleeding in a female.